Thank you, Anna. Right. Ken King and this other man started using them in 1962. Ken King was a lovely person that I met many years ago, and he helped me with my first anatomy course in Memphis, Tennessee. This is a situation where there's lack of attached gingiva here, and here's the post in place. You then make an incision like this and reflect the tissue back, leaving the periosteum, and then you take some tissue from the palate here. Apparently, it is better to put a graft in that's shaped like this. Not at the end of it, it should be slightly V-shaped. It blends in with the tissue better. So this is the graft, and here's the graft in place. Sutured.
Which end should be V-shaped?
Say it again.
I didn't understand which end should be V-shaped when you're placing.
Let me draw it for you.
Do you recommend doing a course for this?
Absolutely. Can you see this?
Yes. Okay.
This blends better. This blends better when you look at it. A year later, you don't notice it quite so much. Okay.
Okay.
I would do a course in also in connective tissue grafting. Okay, Sally, look up connective tissue grafting. I've never done one, but what you do is you make a superficial incision in the palate, you raise the tissue, and you take some of the connective tissue and you use that. Apparently, you get a better appearance.
A periodontist did one such case in my clinic for a patient.
And how was it?
There was some recession in the lower anteriors, which there was still some connective tissue loss. That the graft lost the height again. So the sulcus was shallow and the lip, the frenum was high. So he did a connective tissue graft. He released the frenum, but the result was not very optimal. Like it was okay.
I think that both mucogingival grafts and connective tissue grafts are difficult. There's no reason why a general practitioner shouldn't do them as well as a periodontist. I would do a course on it if you could. You might just see what there is on the internet.
There are a few. There is one good course in Pune itself.
Really? Yeah.
Yeah.
Yeah, I should do it. Okay. See, one of the advantages is that, oh, Abby's coming.
I find it really difficult to understand how do you make a superficial incision without.
How do you?
make a superficial incision without raising the periosteum. And
We just don't go deep. Hi, Abby, how you doing?
Hello, sir. How are you?
Okay, and you've been busy, have you or not?
Not really, sir.
Hmm.
Feeling really good to see you, sir, again.
Say it again.
So feeling extremely good to see you again, sir.
Yes, well, it's lovely to see you, and it's nice to be back with my friends again. And I've appreciated you all when you made little messages to me when I was away. It's been very rewarding.
So you have lost quite a lot of weight, I feel.
Actually, I haven't put on weight, which is the important thing. Okay. It's the advantages of these video cameras. They make me look slimmer than I really am.
Okay, sir.
Anyway, in the end of next year, I hope to come over to India and meet you all again. Okay.
100%, sir.
And to meet Anant for the first time.
Yes.
I'm not prepared to come over, Anant, until I'm allowed to hug you, okay?
Yes.
But I'm not allowed to at the moment, so I can't. Abby,
Hi, all.
Abby,
Hello, everybody. Very glad to see you all again. It's been very long time.
yes, true. Good to see you all.
Thank you, sir. Thank you.
Hi.
Just going back to something else, Ashwin, I need to call my friend about lateral condensing and find out what instrument he uses. Okay, and I'll let you all know.
I use a spreader.
You use a
Spreader.
yes. Is it a electric one?
No,
Okay, that's the way to do it now.
I know. Yeah.
It's just another thing that Ashwin needs to buy. If he does more
So the
endodontic,
one I got. Yeah.
Kylie, you're using rotary or the manual?
Rotary.
what make is that?
The spreader.
I use Pro Taper Gold. Dense ply.
Yeah, and so then you use an accessory cone or something?
I use a single cone technique, but sometimes I do use accessory cones.
Okay.
Sometimes 4% is too small and 6% doesn't fit till the apex. Then I use that 2% accessory cones.
Okay.
Okay, so there's the graft in place, and this is the result. So there's more attached gingiva, or there's some attached gingiva now. It is not absolutely critical to have attached gingiva, but as you know, it's better to have attached gingiva than not have attached gingiva. This is one of the early membranes that was used. This was millipore, made a special type of material called millipore, and it was extremely cheap. It was like sort of $5 each of these. And then suddenly the dental profession got, manufacturers decided they could produce some. So now the membranes are much more expensive. Dr. Hilt Tatum was involved in a study on antigen-matched frozen bone and irradiated bone to see which was the best. Dr. Tatum had a freezer with bone from donors, and they'd do an antigen test before they used it. At this particular time, AIDS started to be something that people knew about, so the study was stopped. You've heard of Brannemark, have you, Anant?
Yes, sir.
Okay. Brannemark was not a dentist, and he produced an implant which was buried, and then you uncovered it 4 to 6 months later. Had he not done that, nobody would be burying implants. The implants I used were not buried. These were the Tatum ones, and the Straumann ones originally weren't buried at all. And they didn't find, in their studies, they found that it didn't make any difference whether you bury them or not. So if you said to me, or if I said to you, I can either put an implant in that's not buried, or I can put one in that's buried, and they'll have to do some surgery on you in 4 to 6 months' time. I'm not sure you'd want the one with that needed extra surgery. This was one of the first stainless steel blades. This was produced by a chap called Ralph Roberts, who I've met, and is just a lovely, nice a man who he's taught here at my place. Just a lovely man. He's a Seventh-day Adventist, so he doesn't work on Saturdays, and he doesn't drink, but he bought me drinks, which I think is wonderful when somebody respects other people's views. He cut this out and wasn't put in until about 3 or 4 years later. When it was put in 1967, Ralph Roberts sent an X-ray of the blade to Leonard Linkow. Leonard Linkow was a wonderful character who I knew very well, and I loved the man, and he was a very bold, brash New York Jew who he was very loud, and he was a lovable man as well. Anyway, Ralph sent him an X-ray of the first blade that was put in, and then Linkow then took a patent out on the blade, although he hadn't produced it himself. And Ralph said, well, it doesn't matter, didn't bother him particularly. So Linkow was very big on promoting blade implants in the 70s and 80s. And these were the different types of implants that were designed by Linkow. This is one of the first blade implant that Tatum made. He bought a sheet of titanium that was 2 foot by 2 foot and 4 millimeters thick, and with a laboratory handpiece going at a maximum of 3,000 revs, he cut this implant and then stuck it in.
How did he do that, sir? How did he? Can you show me that earlier slide where the shape of that blade?
What's your question, Ashwin?
Yeah, how do you just tap it inside?
Yes, you cut a slot.
Okay, you cut a slot, and then so it should be a smaller slot, I guess, or what is it? Just exactly the size?
Ashwin, have you got a Post-it ready?
I've got a book. You can tell me, sir.
You haven't got a Post-it. That's disgraceful.
Give me a minute and get it.
Have you got a Post-it ready, Anand?
No, sir. I'll get one.
And I send you all this time management stuff, and you don't.
I've got.
I have it. I have it.
You can forgive the others.
My friend Errol the other day showed me because he's into computers and mobile telephones and all that sort of thing, and he's all for if he wants to make a note of something, he puts it in his mobile phone or onto his computer. But the other day he showed me a board with he's gone back to using Post-its. And I'll show you mine. This is a whiteboard. Now, just remember that the sticky part of the Post-it is at the top when you put them on a vertical surface. You know about that, don't you, Ashwin?
Yes.
Yeah. Ashwin, those are all the things I haven't done yet.
So what is it with the blade implants, sir, you're saying?
Oh, yeah. Okay. Now, go to my website and go to implantology.
Okay.
And then go to blades and subperiosteals.
Mhm.
And have a look at it, okay?
Okay.
We can't see you, Anand.
I'm just searching for it.
Now, Abby, you can see the presentation there, the X-ray.
Yes, sir.
What's this?
This looks like thyroid.
Abby,
Thyroid bone. Is it?
Abby, this is the buckle
Or
on the lead apron.
Okay.
Okay. Now, about 20 years ago, there was a study which showed that if you use a lead apron, the radiation is directed down towards the patient's gonads by the lead apron. So I haven't used a lead apron since. Does anybody use a lead apron?
No.
I use it.
You shouldn't use it.
I do.
Every time you take an
Sometimes.
X-ray, Abby, think
Yes,
of
sir.
that radiation going down towards the person's gonads, okay?
Okay.
Is it really true?
That was the study, yeah, yeah,
Mm.
okay. Now, if you really want to be perfect, you'd use a thyroid cover. Okay, a little one that just goes over the thyroid. That's the only thing you need to use, okay?
Only for the patient or for us also?
Sorry?
The thyroid collar for the patient, right?
Yes. Yes. You can wear one as well if you want. No, I think it's for the patient. Okay, this is another of Tatum's blades. This is one I came across the other day when I was in Oregon and I was giving this lecture. A lady on the course said, "Oh, I'm going to show you this," and she showed me this. And this was a photograph she took of a patient that came to see her recently. Now there's another. Oh, there's two curious things about this. Okay. Now, Ashwin, I want you to put one of these in next week, if you could, especially in the molar region like this. Do you see the
Yes, I was wondering about that. It's probably buccal or lingual to the nerve.
Exactly. I'm not sure at the moment whether it's buccal or lingual. We need to look at some scans and
Also
see
supporting
which way it
natural-
goes. Because
Yeah, it's also supporting a natural tooth.
So do they expand the plate, bony plate, and then insert this implants, or is it placed at the side?
Ashwin, you know I don't need to answer that question because you're going to be looking at that presentation.
No, no, I didn't ask the question. Anand asked.
Oh, apologize, Ashwin.
So no problem.
You cut a slot. You cut a slot with a Fisher burr sort of thing, okay? But it's in that presentation. I've done maybe half a dozen of these.
I thought all this was outdated, sir. Is it still
Sorry?
being used? I thought all this was outdated.
Well, I mentioned that to Ralph at a meeting about a year ago or 2 years ago, and he said, well, the oldest implants in the States are my implants, which were blade implants, and they were even made of steel, you know. So you have to be very careful about things, saying things are outdated.
Okay.
If you're able to do blade implants, Ramus frames, subperiosteals, and screw implants, if you're able to do all those, if you're able to, and you say one of those is outdated, I'll accept it. But if you're only able to do screw implants, you're saying they're outdated because that justifies you not being an implantologist. I've told you about what a screwologist is. Have I talked to you about screwologists?
Yes.
It was Lenny Linkow who came up with the term screwology, the art of putting screws in and not putting anything else in. So you're not an implantologist. The other thing you'll notice about this, on the X-ray on the right there, you notice it's attached to a natural tooth. Well, the lecturers nowadays would be very upset with that. Hilt Tatum used to do this frequently, and Ralph Roberts used to frequently attach implants to natural teeth.
Yeah, the margin looks beautiful, the crown margin.
Yeah.
Beautiful.
Don't yours all look like that?
Not all the time.
Mm. Can you imagine taking unwaxed floss and flossing up and down on that? It wouldn't catch. Okay.
Then brush.
Do you all use unwaxed floss to check your margins, mesially and distally?
Yes, I use that.
Yes.
Life is a lot easier if you don't. You don't worry so much because you don't know about the catchings. This is a Ramus blade. Ralph Roberts and his brother Harold were working on a cadaver, and one of them said, "Do you know that the Ramus doesn't resorb? So this would be a good place to put implants." So here's one. I've done maybe 4 or 5 of these.
What about
Yes.
the parallelism?
Sorry?
What about the parallelism of the abutment? I mean, can you bend it?
When you buy them, if you can buy them now, there is a thimble that fits onto the head there. which you then cement it on, and then you prepare it. So if that's the blade, you then cement onto it a thing like that. Okay. And you then prepare it parallel with the abutment at the front.
What is that thing made of? The thing that is in the-
Probably titanium.
Okay.
Okay. You have to have special metal cutting burrs. Now this, in the lower there, you can see the blade implants. In the upper, there are some blade implants which didn't succeed. So then a subperiosteal was put on top of it. Would you like to have a patient like that, Ashwin?
No, sir, I want to sleep peacefully.
I think Ashwin would take up alcohol if he was to do that procedure. And he'd be certainly praying to God quite a lot. This is a custom blade. I've almost put in one. I had it almost in place, and then Dr. Tatum took over and did the last bang into the jaw. They come without all those holes in, and you bend it to the shape of the posterior mandible, and then you cut a slot and then you bang it in. I would hate to have to take one out. They are so retentive. So there's one there. This is a Ramus frame. Patient comes in, you do the surgery, you adapt the denture, and they go out in 3 hours. Without having to do a whole lot of grafting, and it's very inexpensive. That frame is probably maybe £300. You bend it to that shape.
How does the denture stay in place?
Say it again.
How does the denture stay in place?
I may have the slide, but the denture fits over the top, and there's some little buttons that you push, and a little nipple thing goes through under the bar. Okay. This is one of Ralph Roberts' cases. Do you see? In this case, apart from putting mini implants in the front there would have to be a fantastic amount of grafting, bone grafting, to be able to put in screw implants.
So basal bone is there. No, now
Yes.
Basal bone.
Yeah.
So
that's all there is.
So is basal implants a possibility?
A basal implant.
Yes.
We may come across one. We may come across one. The interesting thing is that Ralph Roberts in his clinic showed me about 10 cases where he didn't do any grafting and put the implant in, and then the bone increased in diameter. because of the function produced more bone. Ah, here. Do you see that little stud there?
Yes.
Okay. So that fits under the bar.
So what if the patient wants to remove it?
They just
can do it.
they just go like this. They pull it out. They put the fingernail and pull it. It's in two parts. There's the tubing in which it fits like this. Okay, so they just pull it out.
Okay.
Have you got that, Ashwin?
No, the framework is beneath the mucosa.
No.
So this frame is custom made, or
The only part that's below the mucosa is the front foot and the two ends at the back.
Oh,
That's not under the main part of it is not under the tissue.
yeah.
Ashwin, on your poster, look up Ramus frames.
Yes.
And I think that what we ought to do is become a little bit more diverse in our teaching system. And we'll have Ashok give a lecture on Ramus frames and blades. Would that be a good idea, Anand? You've got the job.
He wasn't listening, so it's okay. We'll leave it.
Okay. These were vitreous carbon implants. They were produced by some research workers who were working with a university in California, and they were thoroughly researched. They produced an incredible amount of bone loss because there were cracks in the vitreous carbon, and electrical action occurred between the vitreous carbon and the metal of the framework of it, and they were an absolute and utter disaster. Modern screw implants started in about the 70s with parallel-sided implants like these. Nowadays, most of them are tapered. The advantage is they're easier to put in. And if you're putting them between two teeth, you're less likely to touch the teeth on either side at the apex. In 1970, Tatum started using bone expansion to expand the ridge and then put implants in. Honorary grafting was started in 1971 by taking bone from the chin and from the ramus. Tatum devised this fin implant. I've put in, I think, a dozen or more of these. They're amazingly retentive. The surface area for the bone to attach to is vastly bigger than a tapered implant. This is a staple implant. Is that what you were referring to earlier, Ashwin?
It looks very much similar. Basal implants. It looks similar to the fin implants.
Yeah. These were used in Italy. I think the problem arises if they go wrong. Trying to take one of those out is a little bit of a hazardous business. here's one in place. Also, I think you have to make an incision in the tissue of the chin, in the skin. These are endodontic implants. You prepare the canal and you drill through the canal and then you screw one of these in. I've done about 2 of these. It's a bit ridiculous really, because you're doing it because there's bone loss around the implant. So it's not a very satisfactory thing to do. These are Scrotechie implants. These you cut a vertical channel buccally and then a horizontal one up at the top, and you slide it in from the buccal. A friend of mine's done about 30 of these and they were very successful. These are Italian.
All these are titanium.
Sorry?
Are these all titanium?
They are now. I don't know whether they were originally. Yeah, all the original implants were not titanium. I think titanium probably came in the 80s, 1980s, probably. Nerve repositioning. I've done 2 of these, where you dissect out the inferior dental bundle and put it into under the cheek tissue, and then you graft the where you've taken it from. Sinus grafting was developed in 1975 because Tatum found that onlay grafting in the upper wasn't very satisfactory. This is a sinus graft. As I've probably mentioned to you before, if I was going back to doing clinical dentistry again, I'd want to do 2 things. One is dental health and the other would be sinus grafting. It's a lot of fun. Have you done one yet, Siley? Okay.
No.
I have it planned that sometime I may come over to India and do a course on sinus grafting. Tejas wants me to do one. So in May 1960.
What ENT evaluation?
Say it again.
What ENT evaluation is required before planning a sinus graft?
None. You just get a scan done. Make sure there's no pathology in terms of acute sinusitis. Make sure the sinus is not opaque. It's quite nice if the lining's a little bit thick. It's easier to raise the sinus floor, the lining. I've only once referred a patient to an endodontist, so it's fairly rare. It's a nice story, this, because Tatum woke up one morning having thought about raising the sinus floor. So that day he raised the sinus floor from the crest of the ridge and put an implant in, I think. He then presented this to the Alabama Implant Congress, and then he presented a paper to the the American Academy of Implant Dentistry, and they had a chap called Phil Boyne, who was very famous in America out of California. He was a chairperson of the meeting. And then in 1980, the first publication on sinus grafting was done by Boyne. who didn't mention Tatum's name at all, although he hadn't invented it himself. This is tricalcium phosphate, which was used in the 1979, 80-ish. There's a new beta tricalcium phosphate now that's being used by a friend of mine in London. Have anybody seen this patient before? Have I shown you this? These are intramucosal implants. You take the denture and you have some special drills to drill into the palatal surface, and you put these studs in. You then put the denture into the patient's mouth and have them bite on it for 5 minutes. When you take the denture out, you can see where the indentations are for this, where the little studs are. You then anesthetize the palate, and you then take a special drill which drills through the mucosa only. Ashwin, are you following this? He seems to have disappeared.
Yes, sir. Can you repeat that? Can you repeat that, sir? I
Yes.
have to attend the call in between.
Okay. You take the patient's denture and you fit these into the denture. Cold cure. Okay. You then put this into the patient's mouth and have them bite on it. When you take the denture out, they're the indentations of where these little studs are. You then anesthetize the palate, and with a special drill in a slow handpiece, you drill the little openings for these to go into. Okay, you're not drilling any bone, just the tissue. You then put the denture in, and they keep the denture in for 48 hours. Then they come back, and you very carefully take the denture out. They rinse really well, and you spray their mouth, and you clean the denture. You then have them put the denture back in again. And over the next few weeks, the little holes in the palate epithelialize. Now, this patient worked on a building site, and it was his job to make sure everybody was safe. He was a safety officer. And dealing with building people, he was inclined to swear at them a little bit and shout. And when he came to me, he was having difficulty because his denture kept on falling down. And after I fitted this, it solved the problem. I fitted this when I was practicing in Niagara Falls, Ontario. And I went back there to teach occlusion in Ontario. And one of the participants said, "I've got a patient of yours, Ted Sear," that was his name. And I said, "Oh, can I see him?" So I went to see him. Okay, now, this is what he looks like on X-ray. Okay. This lasted from 1974 to 2012.
Wow.
Okay.
And so when chewing and all, he doesn't have pain now when these buttons hit on the people.
No.
How come? I mean, it's like hitting on the mucosa, right? So
Mind you, you see, he doesn't have a natural dentition against it.
okay, that's that.
So
I
that
think
was
after-
that's 38 years. And he didn't fail, he died. Okay. So I went to see him in Niagara Falls. That's his palate. This was in, this was the, this was in about the year before he died. And this was the denture. It was the same basic part of the denture. He had it relined a little bit in the meantime.
So was he able to eat properly?
Yes. Yeah. Well, a lot better than if he hadn't got them.
Was there any complaint of food lodgement or something?
I don't know. We can't ask him.
Yes.
I mean, less than if he hadn't got them. I mean, do you have complete denture patients complain of food getting under their denture?
Not yet, sir.
Yeah. You see the color of them now?
So can we do it like in a regular practice?
Say it again.
Can we do it in regular practice? Like, can we do it in this time as well? Today as well?
If you could get hold of them, but I'm not sure you can.
Okay.
Well, I mean, it's simple to do. I mean, compared with putting implants into bone, this is much easier.
And so what made you decide to do this denture rather than doing a normal denture?
Say it again.
So what made you decide that you should go for this denture rather than a normal denture? What was your what indication you thought that you should go for this?
Because his normal denture was falling down.
Okay.
I mean, what does a normal denture, what keeps it in place?
The suction
And glue.
glue, right? Yes, sir.
Yeah. So I'd prefer to have this and use glue all the time. I think it's very unfortunate that these aren't used more.
Any disadvantage of this?
Say it again.
Any disadvantage, any known disadvantage of this thing?
Say it again.
So any known disadvantage of using this denture, this type of denture?
Not that I knew of.
Okay.
These implants were produced in 1975, 1980. The only unfortunate thing was they broke at the crown part would break off. There's one in place. This is a sinus implant that Tatum produced to go in when there was inadequate bone. Do you know the expression belts and braces?
No.
Oh, I'm wearing a belt and a belt and braces. Okay, just making sure that my trousers don't fall down. Okay, this is belts and braces. Okay.
The OPG looks cool, sir.
Say it again.
the X-ray looks cool, sir. Like
Yeah.
so many implants.
I don't know how the patient will sit for this.
I think this was done under sedation.
No, even under sedation, sir. I mean, like thinking of this itself will, you know, looking at the OPG itself is so scary.
Well, it frightens Ashwin just looking at the X-ray. Oh dear. Okay, the first two-stage implants were produced by Dr. Tatum. And have you heard of Osseo Integration?
Yes.
Okay, Osseo Integration is when is the junction, the phenomenon that occurs where the bone attaches to the titanium. Okay. Have you heard of ankylosis? Where the tooth attaches to the bone, which makes it difficult to pull the tooth out. Osteointegration was a term that Brannemark produced when, if it had been me, I would have called it ankylosis. It's the same thing, but he needed a special word for it. Now, in 1977, a chap called Jack Lemons, who's a friend of mine, had one of Tatum's implants that had been taken out with a little bit of bone attached to it. And he found that there was a direct bone to implant interface. Previously, with steel implants, it was a fibrous junction, not a bone to implant. Anyway, this was in 1977. In 1978, Jack Lemons produced an article showing about bone to implant surface attachment. Ralph Roberts did the same thing. And then in the early 80s, Brannemark described it. And he got all the credit for it. Everybody thought it was him that invented the whole thing.
I'm going to ask you that because it is all written that he only introduced the two-stage thing and all that.
Say it again.
It is written that he only introduced the two-stage implant process. Brannemark. Like, that's how we hear it.
Yeah, that's not true. That's not true. This is 1977. Okay, Tatum introduced it. And then in 1980, Brannemark came up with it. Brannemark was a bully, extrovert character. I was lecturing in Mangalore with Tatum, and the dean said, "Oh, Brannemark came and lectured to us recently." And he lectured for half an hour, and then he came to me and he said, "How many kits do you want to buy?" He was a very commercial man. Eldo, you knew that Brannemark claimed that he was the first person to produce a two-stage implant.
No, I didn't know that.
No, he claimed it when in fact it was, there were earlier people did it like Tatum. Now, up till 1983, implantology was led by dentists. And then the commercial world took over. And that's where the Brannemark people, they targeted the maxillofacial and oral surgeons and dental schools. And they said that general practitioners should not do implantology. In fact, implantology had been invented by general practitioners. Most of the implantology techniques in the world are invented by general practitioners. This is irradiated cancellous bone. This is cortical bone. This is used for grafting. These are bone blocks. So instead of taking it from the chin or the ramus, you can use these bone blocks. There's been, since the 1990s, many different types of membranes that are produced. Lower ridge expansion in the 90s. I was with Tatum during the time that he developed a lot of these instruments. And then mini implants. What make do you use, Eldo? Can you unmute, Eldo?
Give me that.
What make of mini implants do you use?
Oh, I have Imtech, and presently Genesis has come, Indian made. But I always used to use Imtech.
Yeah. I think this is an Imtech here. Do they come in different sizes?
Yes, from 2.4, 1.8 till 2.1.8, 2.4, 2.8.
Sally, do you do mini implants?
No, I haven't done them.
You must do, okay. You need to be in contact with Eldo to find out what ones to use, okay?
What is the indication? When can we use them?
Denture.
You say it again, Sally.
What all are the indications to use mini implants? I asked.
Thank you for asking. Little old lady, 80 years old, not very high, a very low dental IQ, not much money. What else would you do for this patient, Sally? You're not going to put regular implants in the jaw like that.
Yes, not possible.
Okay.
Okay.
This is what Ashwin's preparing to do. So these are the housings in the denture. This patient came to me with a premolar that was loose, and I took it out and put this in and attached the denture to it. This lady came in, and when she breathed in and out, her front teeth moved in and out as well. You can see the tremendous bone loss there. So I put in these mini implants. These are Imtech. Have you ever used these, Eldo? These fixed bridgework implants? Press your space bar, Eldo.
I have not used square head ones.
Yeah.
I don't have the tool.
I don't know
to
whether
do it.
they make them anymore.
Okay.
Can you join them, all this? Can you join these implants?
Oh, you need to join them together, yeah.
How it will build a framework? What is it? How is it?
There's no framework. You just have a temporary bridge made with a hollow in the side inside it. And then you put cold cure into the denture, into the bridge, and you put it in place, and you take it out a little bit, put it in a bit, take it out, put it in, take it out, so it doesn't set. It doesn't set around the heads of the implants. Then you take it out, trim it up, and you cement it in. You see, unless you've got the kit, you can't do it. This lady came in with a bridge like this, and it had split in, it was loose. You notice the attachment in the lateral incisor there is very small. The lateral incisor on the other side has become decayed. So this came out of the patient's mouth. I cemented the two halves together with Panavia, put in 2 implants. Put some little screws in the lateral incisor and cemented it back again. Now, all of you could not do this because you don't have the kit to do it. This lady came in and her 2 front teeth went in and out, very loose. You see there's no bone around that central incisor. So I took out the loose teeth, prepared all the teeth in the upper, and put in these mini implants. Then later on, I put in some regular implants, and I don't know how many. This is how she was with a temporary bridge on. I replaced the temporary bridge a few years later, and the intention was to put more and more implants in. But over about 20 years, she never actually had the permanent bridge work done. This is the Versailles drill system. This is something that's been developed in the last 10 years. You're familiar with this, aren't you, Eldo?
Yes, yes.
Yeah.
Do you use them, Dr. Eldo?
Yeah, I have a duplicate of this.
How is it?
Not bad.
What's the name?
I got it from Jalandhar.
Okay.
You know Jalandhar company?
Yes. IDS Jalandhar, right?
I don't know if it's called IDS Jalandhar.
I think so, yeah.
Yeah.
They're used clockwise and anti-clockwise. This is the set of drills that are used. And then you put the implant in. That's using them clockwise. If you use them anti-clockwise, it pushes the bone out towards the side. It doesn't drill the bone out. So it increases the density of the wall of the site. They call it densification. Okay. It's really compaction. So you end up with a better socket. Now, if I were using these, which I haven't used, I would use ridge expansion as well. Eldo, have you seen the densification, the Versailles videos? Eldo? In the videos that they show, they strip back the periosteum. They then do their drilling, which breaks some of the crestal bone off. And in one of the videos, they perforate lingually, the lingual plate in the lower. Had they done a combination of ridge expansion and drilling, that would have been better. Are you with us, Ashwin?
Yeah.
Are you going to sleep? What time is it, Ashwin?
15-20 minutes.
What?
Time is 9:50, sir. 10 minutes to 10.
Right. So I'm proposing to go over some anatomy next time. These are the presentations that I use on my anatomy course. Regrettably, the Bristol anatomy department have told me that they're totally booked up next year. So at the moment, my anatomy course will be in 2023, which gives Ashwin plenty of time to save the money. It would be great to have as many of you on that course as possible.
You shouldn't miss it. That is one of the, what to say, the best courses of Stuart. I've attended it thrice, I suppose.
That's where I had the pleasure of Eldo's company and Siley's company when Siley was a young girl. How long ago was that, Siley?
8 years.
8 years.
Oh, nine now.
9 years ago.
2020.
Yeah. Okay.
What do you think about angulated implants, all on 4, the tilted implants, and zygoma implants?
I think zygoma implants are for people like Eldo who are looking for some way of frightening themselves to death.
I'll send you a picture of glabella implant.
Have you done a course on them, Eldo?
No, I've not done a course on zygoma. I want to attend. You know, presently everyone is tilting the implants purposely. Left, right, center, they are tilting it because the multi-unit abutment, you get it in different angulations. So everyone is still, have you, Sally should be knowing, the Dr. Venkat in Hyderabad. He is so famous in that.
No, I don't know.
Okay. So, oh, sorry, Tejas should be knowing.
Tejas, yeah.
Yeah. And he puts implant in every angle and then he connects them with multi-unit and it's so successful. So purposely they are tilting it. So I'm just getting fascinated by it.
prosthetic part difficult or for these
Not very
cases?
difficult because the multi-unit abutment you get it in any angle. From up to 60 degrees you get.
Okay.
I
So-
think that show me a dentist who can do sinus grafting, who also does zygomatic implants, and I'll show you somebody I can respect. But if the person doing zygomatic implants does not know how to do sinus grafting, he's fitting the patient's treatment to what he can do, not what is best for the patient. I think that if you get into implantology, you should get into sinus grafting as a basic thing that you should do. And then some of these other things like zygomatic implants. There was an implant that Brannemark people came up with where you went straight through the ridge into the sinus, into the floor of the orbit. Now that's
Purposely or
definitely something that Ashwin is writing a note to learn how to do.
How do I build my implant practice?
First, you have to buy a fixer dispenser.
I have one.
And then you should start paying the loan of fixer dispenser from implantology. This is how I started my
No, the patients don't get converted for
confidence with which how you present it.
I say the same way. For actually I used to like be more confident of implants rather than crown cutting, like bridge or some prosthetic work. But they just don't seem to be, there don't seem to be enough conversions. There's something wrong, I think. I keep wondering. You know, I thought of buying Densa and everything, but what's the use if I'm not doing enough cases, is what I thought. Then I'm thinking of lowering my charges. Maybe just give them an offer they can't reject or something. Just do cost to cost. I'm very desperate to do implants now.
Yeah, you do it cost to cost in the beginning, and then slowly you charge them more.
Eldo, can you email me those radiographs you sent?
Oh yes, I'll try to, because this has come in a WhatsApp. I'll try to email them.
Just hold on 1 second.
What is this last picture that you put? It's so scary thing. How is it? I mean,
Yeah, this is mucormycosis case.
oh, okay. I was saying, what is it to do with this glabella implant? Okay.
Yeah.
Where is the photo? I can't see.
In the group I've put.
Oh, in the group. Okay.
You see the second picture, it is purposely tilted.
Yeah.
Pterygoid implants. Have you tried pterygoid implants, Stuart?
Sorry?
Pterygoid implants.
No, I haven't. No. And I shouldn't criticize them because I don't know how to do them.
Okay.
If it's a way of treating patients, avoiding doing sinus grafting, then I
Yes.
can't accept that. But if you can do sinus grafting and you decide to do a pterygoid implant, then that's a good thing to do. I think I can send this to myself. I think I've done it, Aldo.
Okay.
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 I want to put that those X-rays into my presentation. Okay.
Okay.
So you're all going to look at blade implants and subperiosteal implants for next time. I'll let you know when that's going to be. It's going to be about 2 weeks.
Okay, sir.
Okie doke. Think of me going around the race circuit on Wednesday and Thursday.
Really?
Oh, I'm going to Spa race circuit.
Okay.
Which car, sir? Which car?
Say it again.
Which car are you using? When you use?
My racing car.
Yes. What
Got a
brand?
racing car.
Say it again.
What
Got a
brand?
racing. He's got a racing car
Brand.
parked
Brand.
just in front of his house.
It's called a Crosley. It is about 218 horsepower. It's very, very neat. A lot of fun. You can see me on, if you go to my website and you go to sport,
I've seen.
you've seen it.
Yes, sir.
Okay. Okay. Okay, everybody. Lovely to be back to see you again.
Okay, sir.
Yes.
Same here.
Thank you.
Cheers then.
Bye-bye,
Bye
sir.
bye.
Bye all.
Bye. Bye. Bye.
Bye. Good night.
Bye.